ISMINS webinars. So good morning, good afternoon, good evening to all the neurosurgeons around the world. And it's time for our ACNS minimally invasive technique webinar. So today our chair is Professor Hiwafumi Nakatomi, who is the professor and senior consultant neurosurgeon of the Division of Surgery of the University of Tokyo in Tokyo, Japan. We have three speakers of today. The first speaker is Professor Masamichi Kurosaki, who is the chairman professor of the Division of Neurosurgery of the Department of Brain and Neurosciences of the Faculty of Medicine of the Tottori University and assistant hospital director of the Tottori University Hospital. His topic today is the treatment strategy for pituitary tumor based on the imaging findings. And our second speaker is the Professor Xinyu, who is the deputy chairman of the neurosurgery of the Tianjin Medical University General Hospital in Tianjin, China. He's also the co-chairman of the cerebrovascular disease surgery and neurointerventional department of the Tianjin General Hospital in China. His topic is emergency sub-temporal approach for clipping of ruptured basilar artery top aneurysms. Our first speaker is Professor Andreas, who is the consultant neurosurgeon and the spinal surgeon of the Edinburgh in the UK and the past veteran of ACNS. His topic today is the Beyond Innovation, Building Ethical and Sustainable System for Global Surgical Impacts. We'll have a UK researcher, Dr. Basilar, who will have a 3 minutes of research report after Professor Andreas' meeting. And we'll also have our special lecture from a chair, Professor Nakatomi, about the management strategy of surgical techniques of the brainstem cavernous malformation. For our discussion today, we have Professor Deepak, who is the director of the Endo and Minimally Invasive Neurosurgery Department, Medanta, the Medicity, Delhi in India. And our second discussion is Professor Asmi, who is the head and senior consultant neurosurgeon of the Department of Neurosurgery, Tunku Hospital, Kuala Lumpur, the Department of the Pediatrics Neurosurgery, Hospital Tunku Asasa, and the Women and Children Hospital, Kuala Lumpur, and the head of the Neurosurgical Services and Ministry of Health in Malaysia. So without further delay, shall I hand over the podium to our chair, Professor Nakatomi, to chair the section.
Okay, thank you very much. My name is Hiro Nakatomi from Japan, and it's a great honor on behalf of ACNS and Minimally Invasive Surgery Society to organize and take a discussion from all of you. And the first speaker will be Professor Kurosaki Masamichi from Tottori University. Please go on.
Yeah, thank you very much for the kind introduction, Mr. Professor Nakatomi. My name is Kurosaki. I'm a neurosurgeon from Tottori University, Japan. One of my specialties is the pituitary tumor. So today I will discuss the evaluation of the WHO classification of pituitary tumors and its relationship with imaging findings. The 2004 WHO classifies adenoma with a T67 labeling index greater than 3% and excessive P53 immunoreactivity and an increased mitotic index as atypical adenomas. These atypical adenomas are more likely to hold a clinically aggressive course with poor prognosis. And we reported a rare case of incidentally diagnosed atypical adenoma. MR imaging demonstrated a pituitary adenoma with superior extension and the tumor slightly complex the optic chiasm, but had no definite invasion into the cavernous sinuses. And endocrinological endonasal transfemoral surgery was performed. The tumor consisted of chromophobic and weak basophilic cells, marked cellular pleomorphism, and frequent mitotic features like this were observed. The percentage of MIB1 positive cells in this tumor was about 20%, and the nuclei of the tumor cells stained strongly for p53, and some of adenoma cells were immunoreactive for ACTH. So the final diagnosis is here, silent corticotroph atypical adenomas at that time. However, a follow-up MRI performed 13 years after the operation revealed no evidence of recurrence. Radiological examination using CT and MRI and PET of the whole body demonstrated neither cerebrospinal nor systemic metastasis. And so with these criteria, the incidence of atypical adenomas were relatively variable, and the prognostic significance could not be established like this case. So therefore, the term atypical adenoma had been no longer recommended. And in this 2017 classification, additional parameters that may be of prognostic significance in pituitary adenomas are listed here, including in the time MRI findings. This slide shows the list of clinically aggressive adenomas, WHO 2017. For example, lactotroph adenoma in men, sparsely granulated somatotroph adenoma, Kruk cell adenoma, and so on. This tumor was discovered during the evaluation of nasal bleeding. MRI revealed the tumor extending from the cella tubercle into the surrounding structure. Because the serum prolactin level was markedly elevated, treatment with cabergoline was initiated. And after starting cabergoline therapy, the prolactin level decreased, and imaging demonstrated tumor shrinkage was after 1 month. However, the patient developed the CSF rhinolayer, endoscopic transsphenoidal tumor resection, and then repair of the CSF leak was performed. Intratumoral diffuse hemorrhage was observed as both an intraoperative and postoperative histopathological findings. Histopathologically, the tumor consisted of atypical prolactin cells, positive cells. The MIB1 labeling index was 6.5%. The fifth edition of the WHO classification, that is newest, of endocrine and neuroendocrine tumor was revised in 2022. A major nomenclature change is the transition from adenoma to pituitary neuroendocrine tumor, so-called PITNET. PITNET occur in 10% of the population. However, the overwhelming majority remain harmless during life, and aggressive and malignant tumors are so rare. Vast majorities of tumors, G1, here G1 is benign. The distinction of D2 and D3 only by the existence of metastasis appears absolutely unsuitable. And this slide shows the high-risk PITNET are listed. For example, sparsely granulated somatotroph tumors, corticotroph tumors, neurocell tumors, and so on. And among them, these two tumors have characteristic MR findings. In somatotroph tumor, T2-weighted MRI signal intensity is a marker for granulation pattern that is densely or sparsely granulated type. Hypointense is almost exclusive to densely granulated type like this. And generally speaking, the sparsely granulated type is more aggressive and less responsive to somatostatin analogs. Therefore, treatment response may be predicted by signal intensity on T2-weighted MRI imaging. Under the new criteria, the overall surgical remission rate for acromegaly has decreased. The most significant factors associated with endocrinological remission are extra-shoot capsular dissection and the presence or absence of cavernous sinus invasion. In this article, the authors described the surgical technique that use the histological shoot caps as surgical capsule, so-called extra-shoot capsular dissection. This patient was admitted to our hospital with acromegaly. On post-contrast T1 weighted images demonstrated that the tumor is clearly depicted as a relatively less enhanced area surrounding the normal pituitary gland, and the tumor is clearly visible as a hypointense mass on T2 weighted images. So preoperative diagnosis, densely granulated type. Generally speaking, the shoot capsule is found more easily in densely granulated type. In this case, a so-called extra shoot capsular dissection was performed. After opening the dura, we identified the interface between the tumor and the normal pituitary gland here, and carefully dissected along the tumor capsule. The tumor was separated from the normal pituitary gland and the medial wall of the left cavernous sinus. And here you can see the inner membrane of the cavernous sinus, no definite invasion. And the unblocked resection was achieved. Then a small decidual tumor was found and subsequently removed. Complete tumor removal was accomplished via the endonasal approach, and endocrinological remission was achieved. The tumor was entirely removed. And the histopathological diagnosis was densely granulated type. This meta-analysis demonstrated the extra-shoot capsular resection contributes more to complete resection and biochemical remission compared with intracapsular resection. Importantly, there were no significant differences in complication rates, including hormone deficiency, diabetes insipidus, or CSF leakage. This slide shows how to remove the inner membrane of the cavernous sinus. This patient was also admitted to our hospital with acromegaly. This case is also acromegaly. On post-contrast T1 weighted images, the tumor, the macro tumor is clearly depicted as a relatively enhanced area. And this video shows this is the extra-shoot capsular resection. Extra-shoot capsular resection was performed. The tumor is relatively fibrous, and extra-shoot capsular resection was performed. Then, because invasion could not be confidently ruled out, then part of the medial wall of the cavernous sinus was resected like this. And after cutting the inner membrane of the cavernous sinus, the oozing was stopped using the material. The patient had an uninventable post-operative course and achieved endocrinological remission. In this article, patients were classified into these three groups based on the relationship between the tumor and cavernous sinuses. Group A, this group A showed no clear invasion. Group B, here, group B, possible invasion, and group C, definite invasion. So in group B, the medial wall of the cavernous sinus was resected in this hospital, was resected when invasion could not be excluded. Then histopathological examination confirmed tumor invasion in cavernous sinus in 56% of evaluable cases, and almost all cases achieved endocrinological remission. This case, sparsely granulated somatral tumors tend to be invasive macro tumors, as I said. These tumors are usually hyper intense on T2 weighted images. However, as in this case, when intratumoral hemorrhage is present, the lesion appears hyperintense on T2 weighted images. So differentiation can be achieved using T2 star weighted imaging. Variable nuclear pleomorphism, including multinuclear cells, can be seen. Abundant fibrous bodies, here you can see abundant fibrous bodies are identified cytokeratin positive. And ultrastructurally, the tumor consists only a few secretory granules and fibrous bodies near the nuclei. And post-operative MRI shows the small residual tumor here. So in this case, endocrinological remission was not achieved. This slide shows the suggested pharmacologic treatment algorithm of acromegaly. The medicine will be selected based on the signal intensity on T2 weighted MRI. And silent cortical tumor is also aggressive tumor. One of the aggressive tumor is non-functioning tumor and clinically aggressive. And second most common subtype after gonadotroph tumors. And characteristic imaging findings are present. On T2 weighted images, you can see that this multiple microcysts were identified in the tumor. This slide shows that some of adenoma cells are immunoreactive for ACTH. So the presence of multiple microcysts in clinically non-functioning macro tumors had a sensitivity of 76% and a specificity of 95% for predicting silent cortical tumors. And in conclusion, the evolution of the WHO classification of pituitary tumors and its association with imaging finding was reviewed. Thank you for your attention.
Thank you very much, Professor Masamichi Kurosaki. He clearly demonstrated how pituitary endocrine tumor has been defined by histologically. Then the history showed there is a big problem around the atypical adenoma, and the remission, functional remission rate is so low. So he demonstrated the importance of the extra So please proceed with the discussion. Professor Azumi, give us a comment.
Thank you very much. Thank you very much for the presentation. So during my first experience also, I tried to preserve the pituitary gland so that we don't want any complication related to hypopituitarism, especially non-functioning and also functioning. But we found that our remission rate was very poor. Then we move aggressively. Now we move to extracapsular removal of the capsule because the capsule sometimes contain the tumor itself and also the compressed gland. Important for us to identify the arachnoid, tumor, and the gland. So that is the first thing. And nowadays also we have changed our strategy to when we open, especially for functioning tumor, acromegaly and Cushing. So we open the part anterior wall, the bone part, so that if we need to excise the cavernous sinus wall, the medial cavernous wall, so we get access. And also we change the strategy that we have more curve towards lateral of equipment so that you can maneuver into the cavernous sinus. And one of the disaster that we had in the process is ICA injury. So the use of intraoperative adjunct like Doppler, and you study the images prior to surgery is very crucial. And the other thing is the development of hemostat agent that make your surgery much more easier, and also the artificial duragen that make the CSF leak incident are very low. So I think the presenters have shown a very important analysis to show that nowadays, especially if you have somatotroph and corticotroph adenoma, so aggressive resection is mandatory. So best to do in the first time, because if you do for the second time, so the scar is already formed. It's very difficult for you to find the plane. So change from towards extracapsular dissection, and make sure that during surgery you have a better view of the cavernous sinus wall. If in doubt, remove the medial cavernous sinus wall. So that is the important thing. But I just want to ask the speakers whether the aggressive method is only applicable for the functional tumor, or for non-functioning adenoma, do you do the same thing?
Thank you for a nice comment. In our hospital, we do the aggressive tumor resection for functioning adenoma. For example, Cushing or acromegaly, as I showed. But non-functioning adenoma, sometimes we do the extracapsular resection. For example, the silent corticotroph tumor or neurocellular adenoma or something. But usually we do the intra-tumor removal for functioning adenoma. If the tumor regrows from the residual tumor, we do second operation or gamma knife or radiation therapy. Thank you.
Yep. Okay. Thanks.
Thank you very much. We have another question from Dr. Shawaras Biswas. Please.
Thank you, Sensei.
Yes.
There are multiple practical problems we have faced in case of functional tumor, especially in ACTH secreting pituitary adenoma. Patient is symptomatic, but MRI shows no definitive lesion. We also have done IPSS sampling, but there is no lateralization of the lesion. In that case, should we go for extensive resection of the tumor? This is number one question. And number two, we know that functional tumor oftenly invade the medial wall of the cavernous sinus, the caroticlinodal ligament or palaceral ligament. So in those cases, should you also routinely check the medial wall of the cavernous sinus?
Okay. Number one, I answered regarding the Cushing.
Yeah.
One of the problem is the diagnosis of the micro tumor, minute tumor. Sometimes the dynamic MRI is not so good. I think the spatial is not so good. We do the post-contrast T1 weighted images, SPGL, SPGL method. So the diagnosis rate is so high, but in some cases, as you said, we do the Cavernous sampling. In such a case, if the tumor in the MRI show that small tumor and the side is okay, so I will do the operate. But unfortunately, there were no negative MRI and no definite catheter. So we wait and MRI follow. The second question is the cavernous sinus invasion in the membrane. We sometimes, as I said, in a functioning tumor, we do if the tumor invasion is confident, so we open the in the membrane with the cavernous sinus. But no, sometimes was so difficult. So non-functioning tumor, we don't do that. Thank you.
Oh, thank you. Since just one additional question I want to ask. In case of pituitary apoplexy, which is a large functioning tumor, should we go for routinely opening the medial wall of the cavernous sinus?
The pituitary apoplexy, we do if the patient visual disturbance or acute operation, but no, we don't open the cavernous sinus.
Oh, okay, Sensei. Thank you so much.
Thank you.
Thank you very much, everyone. We had a lot of the nice discussion, and we hope by learning the tips and the pitfalls from experts like Professor Kurosaki, we can improve our functional and the cure rate for all of us. You have another question, Doctor? Okay, very
Yes,
quickly,
Sensei.
please.
Yes, Sensei. One very short question.
Okay.
Probably I missed few slides. That is, what is the protocol to diagnose a silent corticotroph functioning tumor? Sensei, nice presentation.
Thank you. Silent corticotroph.
Silent corticotroph tumor. Yes.
He is asking how to diagnose the silent corticotroph adenoma.
Preoperatively, you mean?
Yes.
Yes, Sensei. Yes, Sensei.
I showed a typical silent corticotroph tumor, multiple microcysts on T2 weighted images, and also invasive the cavernous sinuses. So then later I will check the pathology. So important finding is the preoperatively the multiple microcysts. Thank you.
Great question and answer. Great discussion. Thank you very much. Then let's move on to the next speaker. Do we have Mr. Yan Xinyu already?
Hi, Professor Nakatomi.
Yeah, great to see you.
I'm ready.
Thank you. Yeah. Please proceed with the talk. He's talking about the emergency sub-temporal approach for the clipping for ruptured basilar top aneurysm. Please proceed.
Okay, thank you very much.
Sure.
I'm very honored to see all the professors today, and let me share. Oh, where is the share? Oh, here. Right. Okay, today I'm very happy to have this chance to share and discuss with all the professors about clipping of the basilar top ruptured aneurysm. And as we know, about 200 years before our mentor's mentor, they start treating aneurysm for the ruptured ones. And in the recent years, clipping and endovascular treatment developed very fast. But compare each method, like clipping and coiling for ruptured aneurysm, there's some advance and the disadvantage of both methods. For our understanding, open clipping has a good result and very stable for the patient, but the coiling may be more minimal invasive and accepted by the patients. Another question is that the doctor training is different. For clipping rupture aneurysm, neurosurgeons, especially young neurosurgeons, need long time of training. And on the other way, coiling is some easy. It's needed short time. But consider the acceptance of patient. Every patient don't want open surgery, they want coiling, they want endovascular treatment. So what we need to consider is that how we to do our work like clipping to minimize the injury to the patient to achieve good results. That clipping will be accepted by the patient as the coiling in that way. In the year of 2018, there is a report, a multi-central retrospective study reports that there is a little bit higher mortality for coiling for the ruptured aneurysm. So for this consideration and combined with some mono-central reports in the large volume clipping unit centers of neurosurgery, they have very good results also compared to the coiling. But for the very special position of the basilar top aneurysm, the report of clipping reduced from last century to recent 20 years. So that means most of the ruptured basilar top aneurysm were coiled by the endovascular tube. So for with review of all treatment methods, the interventional methods, including coiling, stent-assisted coiling, and the fluid diverter, and the fluid interpreter, like WAP. On the open surgery side, clipping is the traditional method, and in recent years, we have endoscopy, and another, finally, we still have another traditional method is bypass and trimming. So like this small aneurysm in the basilar top with a stent assist, we can reach very good result with the interventional team. This is very acceptable by the patients. So, and in recent years, the interpreted flow of the device like wipe is applied to many of the basilar top aneurysm. It's very easy and it's very convenient for the neurosurgeon, for the endovascular team to do the surgery. And with endoscopy, we can approach to the basilar top. But with endoscopy, there's still some question we need to consider about. First, under the endoscopy, this is 2D underview, not 3D. But under microscopy, we can view the aneurysm, we can see the nerves and structures in 3D, 3D way. And under microscopy, the operator need to replace the endoscopy and move their hands steadily. And in that situation for a ruptured aneurysm, what if the aneurysm ruptured during the procedure? That may be more difficult to control the rupture compared to the microscopy. The last question for basically top aneurysm is the very giant aneurysm like the PCA and SCA both run out of the body of the aneurysm. For this kind of giant aneurysm, simply clipping may be very dangerous for the patient. So bypass and the treating may be an alternative method. But this is a very rare condition. We have very rare cases. We don't have that's more experience to report what's the results, how the method could be work. So today I just present the sub-temporal approach. The first report is from Professor Jack and Professor Johan in 1996. It's compared to other methods of open surgery. The sub-temporal approach have a short walking distance from the surface to the basilar top aneurysm and could avoid post-clinoid pulses and have a better view for the aneurysm neck and a better view for the perforators. And it's easy for apply temporary clippers, but still I recommend that don't apply to the big or giant one aneurysms, especially for the ruptured aneurysm. And for the sub-temporal approach, we need to consider the language, optic radiation, and range of Labbe. We should compare the function of the patient. So that is the anatomy is easy, and this is the position of the patient and the craniotomy. The first tip is that open the craniotomy as low as possible for the middle cranial fossa. So we open the surgery, we can see the tendon very easy. And the second tip is that release the CSF before we detect, before we approaching to the aneurysm. So and for the rupture, especially for the rupture one, we need to control the pressure of the intracranial pressure, release the CSF after craniotomy. We can put the tube before surgery, but we release CSF after craniotomy. And another question is, there is no landmarks for the sub-temporal approach beside the tender. When we open the tender, we see the chocolate nerve first, but for the ruptured aneurysm, there is the subarachnoid hemorrhage surrounding the middle brain. So we cannot see very clear where are we. So we touch the tendon to open the space between the subtemporal and the middle brain. And when we follow the trochlea, we can see the oculomotor nerve, the third nerve, and then we can see the PCA and SCA. So until this time, we get the anatomy landmark. So this is the final picture with my first case. We applied apply it. So we can move to the video of this case. But before we move into the video, we can compare the surgical fields of perioral approach and the subtemporal approach. With the right side of the perioral approach, we need to find the aneurysm between the internal carotid artery and the optic nerve. I think if the view of subtemporal approach is better. So this patient, the first case, this patient is with a ruptured aneurysm and a subarachnoid hemorrhage, and the aneurysm is so small and the CT angiography, and with DSA, we can see the aneurysm is also very small. So we decided to perform aneurysm clipping. So, okay, this is the video of the first case. So after releasing the CSF, we cut the tendon, and we see the chocolate nerve beneath the tendon. So after release the CSF, the brain is so relaxed, so we can go with the chocolate nerve to the toward to the ruptured aneurysm. So we can see the hemorrhage here. If the hemorrhage is covering the middle brain. So when we dissected the chocolate nerve, we need to find the oculomotor nerve. So this is the oculomotor nerve and the PCA we found under some perforators beneath the oculomotor nerve. So that's we found the direction. So this is the basilar artery and the control lateral P1. So this is the basilar artery. So we don't want to say the aneurysm at this time. We want to apply primary control for the basilar artery and control it PCA. So we can have a safe dissection of the aneurysm neck. So this is working in front of the middle brain. So combined with the CT angiography and the DSA, we know that the aneurysm is in the center of this field. So we apply the first temporal occlude clipper in the basilar artery. And then we apply another one to the P1 of the controlate of the other side. So the aneurysm is almost controlled under our hands. So we try to find the neck of the aneurysm. So we can see here is the aneurysm neck, very small aneurysm. It's maybe only 1.5 in diameter. So we want to see more clear. This is the aneurysm, but this time we see what happened. We see aneurysm rupture, but we have make a control for the PA and the control other side P1. So we can apply another temporary clipper for the same side of the P1. So the aneurysm is almost tripping temporary treatment. So we apply the caliper for the ruptured aneurysm. It's not very difficult, although it's in front of the middle brain. So we can remove the temporal caliper, and we can check our work. So we can see the rupture point of the very small aneurysm here. This is the rupture point here. So we apply another one of the very small aneurysm caliper. We have put 2 calipers. So this is post-surgery of the patient and the CT angiography. You can see we do is acceptable. The patient have a third nerve palsy, but it is recovered 2 months later. So this is another case. We have this one of the rupture aneurysm, and this is this one can be coiled. We think we can coil and with stent assist, and we can put stent in the left side of the PCA and the basilar artery, but the patient accepted the surgery. He's 67 years old. His family member have aneurysm and died post coiling. So patient want open surgery. So we performed surgery, and we can see the second video. The working method is the same for the lumbar puncture and the CSF drainage first, and with working along the chocolate nerve and the oculomotor nerve, and dissecting the ironic memories, and with with clearing of this hemorrhage to find where is the PCA and the SCA first in front of the middle brain. So this aneurysm is bigger than the first one, so we can approaching with the SCA to the BA on the other side of the PCA, so we can keep the aneurysm intact before we apply the temporary clipper. So we can see the BA first, and we can see the perforator for the Brainstem on the BA. But I'm very scared when I do manual calculator under this situation. I know that these perforators of the BA is very important because I'm working before the middle brain. So after temporary clipping applied, I apply clipper, strike the street clipper for the aneurysm, for the neck of the aneurysm. You can see this is a curved aneurysm clipper. First one is a straight one. So with straight one, I can now see it's very clear. I cannot see the aneurysm like very clear. So we change it to the curved clipper. Okay, this is the post-surgery CT angiography. You can see very good results, to my opinion. Oh, this is the patient. He's very happy. He recovered totally without any morbidity. And this is the third case is a male, is a man of 58 with subretinal hemorrhage, and we can see there's some vasospasm of the rupture of the aneurysm, and also the aneurysm is irregular, maybe due to the vasospasm, and the aneurysm cannot show very good. But this patient also, this case is about the 4 years before. That is during the COVID-19 period. We don't have the supplier of the endovascular scan or corridor, so very effective. So we have to operate for this patient. So to my opinion, surgery is very important. Surgery is save life under some circumstances without the intervention of doctors, without equipment. We have to open surgery for the patients. This approach is from the left side. Those two cases is from the right side. This is chocolate nerve. This is and the middle brain, and yes, this is the third nerve. We need dissected to find the PCA and the BA. So this is the BA where we can apply the temporary clipper to make a control for the blood flow from this BA. And then we can say third nerve and the very tiny pickup. That is very small one is the pickup. And we can detach and clear the blood to say the neck of the aneurysm. We can say that's the neck beneath the articulator, absorber, and the tip of this. Here is the neck of the aneurysm. So we apply the clipper here. So because this time the aneurysm may be ruptured again, but we apply the clipper in right position, so we can remove the temporary clipper without difficulty, and washing the subarachnoid hemorrhage and reduce the vasospasm. So this is the post-surgery CT angiography. We can see a right position of the clipper, only one clipper here, and the patient recovered very quickly, to my surprise. But even we have often tricky, but he recovered very good. We can say only 10 days post the surgery, he can walk in, he can move. So that's my report. Thank you very much.
Thank you very much, Professor Yan Xinyu. It's a great, fantastic presentation, and your hands are so steady, and even with narrow field, you did great. Thank you very much. And you are summarizing the surgical subtemporal technique to the basilar top area. So we have a discussion today. Professor Demetriades,
Yes, sir.
please, give us a comment.
It's a excellent and great this one is approach. So it is definitely a very great approach. Subtemporal approach is directly to the root, and definitely the excellent look directly go to the behind the cella. That's definitely a great approach. But definitely there are other approaches also to deal with organozygomatic approaches there. And the other approach are definitely familiar to us, but this approach is a shorter distance that professor has shows a very Directly, you can go directly, open the tent, and then you can see the third and fourth node and directly to the this one aneurysm. That's a very great approach. But sometimes there is a temporal lobe retraction is the required. So when there is a edema and there is a rupture aneurysm already before, so definitely temporal lobe retraction causes some problem. Sometimes there is a poor visualization of the contralateral vessels. Sometimes the P1 is very restricted. Sometimes you can very difficult to see the contralateral vessels of SCA and P1 also. So what your opinion, Professor? Sometimes there's what is about your opinion where the contralateral vessels is very easy as compared to other approaches as compared to this approach. What do you think? Prof?
Professor,
Yeah.
Professor
Yeah.
Yang,
Yeah.
he's
I'm here.
asking about the contralateral control through
Yeah.
the subtemporal approach. Then,
Yeah.
do you have any special attention to secure the contralateral branches? For example, Professor Deepak might asking to use the frontotemporal transsylvian to see the
Yes.
opposite
Yes.
side. What do
That's
you think?
actually, yeah.
Yeah.
Okay, I totally agree with the Dr. Deepak's consideration. And when we clipping aneurysm, we need to see all the fields of all the muscles, both side and on the other side. And with very small one, like my first case, it's easy to see the other side. It's because the aneurysm is so small. But with some aneurysm with like diameter of 5 millimeter, we cannot see the other size. So in my second and the third case, I cannot see the control side of the PCA. Yes, of course, I cannot see it. I only can imagine the position by reading the CT angiography and the 3D of the DSA to make an impression where is the PCA and of the other side. So my opinion is that the very big ones and we don't apply subtemporal approach, and I think endovascular may be safe and easy for doctors and patients. Thank you.
Thank you.
Okay, we have another two questions. Professor Ben, please.
Yes, and thank you, Professor Yang, for your great sharing about the clipping of the basilar artery, which is getting less and less. I would like to ask about in your experience, and so with the Sub-temporal approach, is there any occasion then you have to drill the posterior chinoid process to apply the and any situation that we have to consider? And my second question is for those giant basilar artery aneurysm, I saw cases from Japanese surgeon that they do the bypass to reduce the flow to the aneurysm to try to induce the thrombosis. And for example, doing the SDAP2 bypasses and trapping to induce the thrombosis. So what is your opinion? Thank you so much.
Okay, thank you. Very good questions. And for the first question, the post-process clinoid is an obstacle, and maybe cover the view of the aneurysm when the top of the BA is too high or too low. So from the terminal approach, and that's me. I see. I remember. I was once upon a time. I see a video of Professor Lawton. He drilled the post clinoid process after open, and but his case is unruptured one. With the rupture aneurysm, I'm afraid during the procedure, if we drill the post clinoid process, and if is very small action of the uncontrolled action, maybe rupture happen for the ruptured aneurysm. So for ruptured one and for not big one, like small and diameter under 5 or 6 milliliter, I'm prefer for the subtemporal approach. And from this direction, we can avoid the post clinoid process. It's just on the beside the aneurysm. We can see both these two structures very clear and easy to apply temporal control clippers. So this is the first question. Second is that the bypass and the flow control method for treatment for the variant based top aneurysm. I think it's a very good, very good choice until now. Even with flow diverter with so many stent coils and like a new device like web. And but sometimes when the PCA and SA, even the SA running out of the body of the aneurysm, we cannot apply the endovascular method. So bypass may be from the external crowd artery to the PCA from the one side and occlude the basilar artery or occlude the vertebrally artery. Maybe we can reverse the flow, blood flow for the aneurysm. That maybe have some function of the treatment to prevent the rupture for those GN aneurysm isn't enough. Patient need good function post surgery. So, but this is a case report, just the case report, and we don't have so many patients, and we cannot summarize the right choice, which one is good for the patients. The traditional method is to performing multi-central clinical trial. But for this case, for this point of the aneurysm, we cannot perform that studies. We can only depend on the experts of the neurosurgeons and the endovascular teams. If we cannot perform direct clipping and direct easy endovascular treatments, the only thing we can do for patients is the bypass and reverse the flow directions for the patient. Thank you.
Okay, thank you very much, everyone. Yeah, and we have to learn, like Professor Yan's master's experience, and keep in mind what is important. And also, we have to be flexible to combine endovascular technology plus skull-based approaches for grave disease. Skull-based approach might help us to open up wider window to see both unilateral sides as well as the contralateral side. So let's move on to the third speaker. Thank you very much, Professor Yang. And we are going to move on to the third speaker. We have Professor Andreas from UK. Are you there?
Hello. Yes, hello to everyone. Thank you for your kind invitation, Mr. Chairman and dear colleagues and friends. Let me make this presenter's view.
Yes, please go ahead.
Thank you. So this topic is slightly different to technical presentation. I chose it because the mission of the ACNS and the ISMINS, but also the ANS, where I have been involved, is to extend training.
Alert from Microsoft PowerPoint.
Training.
Continue to share this PowerPoint window.
So sorry about that. The mission is to extend our training and our service and the quality of care to our patients. And I think now we are seeing intercontinental collaborations, which are hopefully going to build a lot further in the future. I have no financial disclosures. I work in Edinburgh, which is celebrating this year its 300-year anniversary as a medical school, whereas the hospital itself has already surpassed the 150 years of general medicine. The agenda is to introduce a little bit of the burden of global surgery, discuss some ethical pillars, but also some sustainability challenges, propose some potential strategies for solutions, and of course have a discussion if time allows. The global surgery burden is quite large. It has always been neglected up until the last 10-15 years after the Lancet Global Surgery Commission put it back in the forefront. And we can now estimate that 5 billion people worldwide lack safe, affordable and surgical and anesthetic care. That's a massive number. And 22.6 million per year of those are the estimated neurosurgical caseload, which also translates to more than 5 million untreated neurosurgical cases in low middle income countries per year. Now, TBI, traumatic brain injury, seems to be concentrated more in low middle income settings. It's, for example, as you can see there, even we have good data from India to support that. There are persistent barriers that have already been identified, including workforce shortages, geographic access constraints, out-of-pocket costs, because in many areas patients are required to pay for their treatment, or their families are burdened with that, even if the patient is unconscious or on ICU. And this leads to a large unmet need. And at some point, we need to start thinking beyond or rethink the innovation of global surgery. It's nice to have a theme that we can champion, but we have to acknowledge that there are some limits of pure innovation, because innovation alone is not sufficient. And neurosurgery in many ways requires frugal technology, and it must avoid paternalism, where high income country people go to low or low middle income country areas and become paternal. So the relationships have to change, because simply exporting technology without context in the long run can be counterproductive. So one of the ways forward is to focus on sustainable models. There are risks, including the infrastructure shortages in Africa and Asia, Latin America, but also some parts of Europe. We need to try and focus a shift from towards task sharing and towards building trust within those collaborations that can hopefully survive the test of time. Some of the ethical pillars in global surgery are shown here. We have clinical ethics, which addresses end-of-life care, trauma prioritization, and so on, things being critical in resource-constrained environments. We have research ethics, whereby inclusive design of trials, accountability, and so on are paramount, and research should be designed and co-created with local partners in mind to ensure relevance and to ensure ethical integrity. There are education ethics, whereby bi-directional training and cultural humility are essential. And education has to and must be a two-way exchange, respecting the local knowledge, respecting the local practice, and introducing some of the new innovation. There are also partnership ethics, whereby trust and local needs assessment need to be respected from the foundation upwards, and partnerships must be built on mutual respect and a deep understanding of community-specific challenges. Beyond this, there are also challenges in the sustainability of surgery, but also neurosurgery, and some of those include the environmental impact of surgical practices. We have operating room waste. You can see this in every day in our own departments. We have emissions from anesthetics and from imaging. We as surgeons are quite naive to these things, but our radiology colleagues and our anesthetic colleagues are much more aware and making us hopefully more aware. And there is scalability in the low middle income country setting, these issues hinder the scalability of surgical services where resources are already limited. So how do we move forward? How do we develop sustainability strategies for neurosurgery specifically? We could think of something called the 5 R's: reduce, reuse, recycle, recover, redesign. And this is a complicated exercise which involves many people outside our well-defined and well-protected operating rooms to achieve sustainability, quality improvements, to look at reusable sets or rational sets. Even if there are some disposable sets that you can see there on the right, they have to be rational. We need to think of low carbon alternatives. For example, adopting total intravenous anesthesia over volatile agents, using smart imaging can reduce the carbon footprint of certain surgical procedures. And you will have noticed, hopefully, that in some high impact journals, including the Lancet, there are now discussions about the carbon footprint of specific operations. The challenge is to build ethical and sustainable systems. And it's crucial to avoid one-way dynamics. It's also crucial to ensure ethical and inclusive development that benefits the local communities. And there are 3 points I want to make here. The first one is a phased partnership approach, whereby we need to initiate some collaboration, then develop it, and then maintain it. In the local ecosystem development, we need to build things that require government support, because if there is no government support, if there's no adaptability, if there's no communication, this will not survive the test of time. And then also we need to move from individual to team or community morality and ethics. Avoid ego missions where I go somewhere, I feel great just because I did 1 week or 2 weeks worth of operating. We need to teach someone to fish as opposed to give them fish. We need to think global and act local. So this means inclusive development, it means equal partnerships. And the EANS has made some humble beginnings in this, if you like, in our journal called Brain and Spine, which I encourage you to submit to, new impact factor 2.7 within the last 2-3 years. But the aim here is to encourage all 3 phases: to initiate, to develop, and to maintain. The initiation includes trust, includes personal connections, includes systematic planning, laying the foundations, taking into account the local context and the needs, but also nurturing institutional and governmental support. The development phase is about capacity building, developing skills, supporting academic and research growth, and being astute to challenges in the development and the adaptation. And then how do you make it last? How do you make it survive? The maintenance phase refers to sustainability, independence, proper resourcing, proper logistical support, good communication, continuous commitment, and of course, how do we prove to governments, how do we prove to funders that this is worth it? By having good outcome measures, by having good accountability. The recommendations for action are about implementing ethical and sustainable practice. And the ethics curricula need to come into our day-to-day work, not so much as a theoretical concept, but as a practical concept where we can develop neurosurgery specific ethics curricula. We can talk about autonomy, artificial intelligence, phase training programs at all levels of practitioners, bottom up and bottom down. We need to develop metrics for success with key performance indicators for operating rooms that combine efficiency metrics as well as patient outcome data. We need to foster collaborations with institutional support that can build capacity and share resources effectively. Now, in the bottom, you can see some of the efforts from the EANS. On the bottom left is one of our publications in Brain and Spine, where we have initiated, tested, and now have continued to support education in Africa through EANS developed courses, which will hopefully be taken over by colleagues in the African continent and delivered on their own. We dedicated the Congress of 2023, the ANS Congress 2023, when I was president. The content and the topic was neurosurgery and technology at the service of humanity. And then we also, if you see on the bottom right, the low and middle income countries' perspective on collaborations, where we asked the people that are being visited what they think of collaborations, to make sure we do not have a paternalistic viewpoint only. And then we have done some work on recommendations on how to initiate, how to develop, and how to sustain such collaborations. And you can see here the map of green means there's a lot of relevant factors that need to be taken into account, and lots of recommendations in this article, which is open access, and please feel free to download it when you get a chance. Some of these recommendations, in summary: to initiate stage 1, build mutual trust, avoid paternalistic dynamics, avoid colonialism, engage local institutions, and define shared goals, so we all have the clear picture of what we're targeting. At the stage 2 of development, this has to be adapted to the local context. It has to encourage bidirectional knowledge exchange. It will benefit if persons are trained properly in an inclusive system and program. And to maintain, we need sufficiency, self-sufficiency locally. We need sustainability of equipment, continuous communication, and equity of what is being built at the local ground. A scalable and independent future will leverage technology. We can improve on things that are already proven to be successful and useful, such as telemedicine. We need task sharing models that promote independence and reduce the dependence from external support. And one of those ways is to create twinning programs between, let's say, certain countries on the richer side and others on the poorer side or less resource side. We need to position surgeons to lead in delivering this ethical and sustainable care on a global scale. I think we are well placed because surgery has a lot to offer and has over the last few years received its due attention. So to join the movement for global surgery, we need to engage with initiatives and support networks. And we have here the ACNS and the ISMINS under the guidance of Professor Yoko Kato, who is also helping with the WFNS Foundation. We need to commit to action and collaborate on long and sustainable partnerships. I wanted to thank the Global and Humanitarian Neurosurgery Committee, something I started in 2021 of the ENS, and now they're doing fantastic work. I'm so proud of them even after I have handed over. The College of Surgeons East Central and Southern Africa for their collaboration, and the Continental Association of African Neurosurgical Societies for their support in our work so far. Of course, big thank you to all of you here today for your kind invitation and attention. Thank you.
Thank you very much, Professor Demetriades, and your global surgery presentation is so stimulating and inspiring all of us, and you are so motivated and contributed to the world. Thank you. Any questions from the audience? Please, Professor Ben.
Yes, Professor Andreas, really great work, and I really appreciate your effort in breaking the barrier between the European society and also the low-income country. I would like to ask about. I think there are more and more exchange activities between the Europe side or US side, or even Asia side with the African neurosurgical units. So I think it's also good for those young neurosurgeons to have some exchange activities between these developing and also the developed countries. So how do you see the see the trend? So is currently like the ANS promoting this kind of the exchange program between like let's say two different units in two different countries? I would like to know about the status. Thanks.
Thank you, Ben. The concept of going somewhere on a mission to support an area or a department or a colleague who has less resources is nothing new. It's obviously very long-standing, and a lot of people do that. What we have tried to do is to provide a structure and a framework based on ethical principles, because we don't want people to go there to do these ego missions. In other words, when someone can be there for a week or two, do a lot of work, but then when they go home, they leave behind a problem of gap of support. For example, if I go and do 20 super difficult complex spine cases or skull-based cases, but there is no infrastructure to look after these patients afterwards, I think we're generating a fallacy of support. The opposite would be where we go there and we team up with the local colleagues and ask them what is the gap here? What is the infrastructure gap? What is the training gap? And what is the way to, a sustainable way to try and bridge this gap? And this is not an easy task in many ways, but it involves the surgeons, the doctors collaborating, identifying and putting egos aside, from both sides, to find a way to engage with local health ministries and government support, because without that support, without the long-term funding, nothing will survive. Now, trainees can play a part in this as long as it's ethically acceptable. So I wouldn't like my trainee to go to a poorer country where there are huge acoustic neuromas to go and do work without being properly trained, because those patients deserve as much care and attention as the ones in the home institution. So we should avoid people going somewhere to practice. You know, this is about building sustainable services, and therefore we can integrate visits within a certain training structure. We can allow doctors from Japan and Europe and America to go to poorer countries. And of course, bear in mind that poor countries can be only 1 hour away. It can even be within the same country, poor areas. It doesn't have to be different continent, but going to a different area of poor resource in a different context can be built into training programs which are continuous. In other words, you can send faculty, you can send trainees, you can receive trainees, and this will lead to a symbiotic relationship that is long-standing. Some of you asked me about the method. Well, one method is to have twinning programs. We are slowly developing that, and by twinning programs, we mean that, let's say, Department A in high-income country teams up with Department X in low-income country. They can have online morbidity mortality meetings. They can have online multidisciplinary team meetings. Then there's a visit. Then there's a longer visit. Then there's a trainee exchange from both sides, because we can also learn. A high-income country doctor can learn about different pathology and different natural history of pathology when they visit a low-income country. But it's a complex terrain, and I think it has to be navigated with some structure. Thank you.
Yes, totally agree. Thank you so much, Professor Andreas, for your opinion.
Any other comments? I think you summarize the problem of this global neurosurgery, and the key will be develop or create the local team members to finding out a way to start from there. And then we can stimulate several aspects by exporting skills or some materials. But the key will be that use the local members and motivate them to build up the nicer, better team from their own. Is that right?
Yes, absolutely. Professor Nakatomi, you're absolutely right. The ideal mission would be that in the end it is no longer necessary. In other words, if a mission manages to build an infrastructure such that the visitors are no longer needed, then it means they have built an ecosystem that can take over, and that would be the ideal goal. Yes.
May I add some
Yes,
comment?
Yes,
Yeah.
please.
So I think this global surgical initiative is very useful. So I use this and practice at local level. So as a national health services, so I use a global surgery as a pushing factor to the policymaker in the country. So for example, if you look at in our country, we are looking at the patient safety, treatment should be delivered in timely manner, equity, patient-centered, and so on. So we try to adopt the global surgery. For example, they use the KPI that which Demetriades mentioned, the metric for success, the bellwether. For example, 2 hours in our country, they only set for C-section, for gynae or NG, and then open fracture and laparotomy. So we are pushing the government so that we can get the 2 hours or minimum 4 hours for subdural hematoma to get into theater, so that you can get immediate access. So that's number one. And number two, we also use because a timely manner of global surgery, so we try to reduce the third delay. So in other words, the patient come to the hospital but don't have access to the OT and don't have the access to ICU. So using this parameter, we get more access, and nowadays it's quite easy to get ICU for all neurosurgical service. And also in my country, we have about 28 centers, so that we can distribute the neurosurgeon in a high dense population to low dense population, from the big city to the remote city, so that we have equally distribute using this global surgery initiative. And we also learn from other countries, not only developed countries, because we must understand at the end of the day, to run a medical services is very expensive. So sometimes you can only do what is superb in universities or in a big city, but you cannot do in a peripheral city. So you have to adopt. So exchanging experience from developing country or underdeveloped country can be very useful. Distribution of the expert, of course, sharing, even the developed country also can learn from the developing country, because of the distribution of the cases can be different. So I think this global surgical initiative is, especially in neurosurgery, is very important. And those leaders or the young generation, I think, should take the lead to get involved, because you can change the policy, you can even influence your government, you can get a better resources rather than we focusing on the surgical expert alone. So I salute those people working on it, especially Andreas, and we have Kipak also, at the world level. I support this kind of initiative. Well done.
Thank you, Asmi. Thank you, Professor Alias. There are many people who do this much better than me. I'm just trying to, like you, add a little stone.
Thanks.
Yeah,
Wonderful.
great work. Thank you very much. And especially we are now using the AI and the digital content or communication technology. These global neurosurgery process will hurry up or speed up sooner or later. Okay. So let's move on to the next research report. Dr. Bilal, are you ready?
Hi, yes, I'm ready. Sorry for my voice. I'm feeling a bit under the weather at the moment, but ready to present.
Yes, please proceed.
Okay. Let me share my screen. Can you see my screen?
Yes.
Perfect. Thank you very much. Hi, everyone. Thank you very much for the invitation to present some of my research I'll be doing here at Fujita. My name is Al Siddiq. I'm a medical student from the University of Edinburgh. I'm also a PhD student from the University of Edinburgh, and I'm here with Professor Kato for the next month, focused on vascular neurosurgery for my clinical elective. And the project I'm focused on is looking at the impact of 3D MRI and CTA reconstruction in STA-MCA bypass surgical workflow. So I don't think I need to explain to this audience, but we know that STA-MCA bypass surgery is the most common kind of extracranial, intracranial bypass surgery, often used for disease such as moya or for strokes. And I think a key part of this is that the surgery requires a lot of complex steps. There's not much research really around in this topic. So what we sought to do was we wanted to really understand or see whether adding extra 3D imaging can improve surgical workflow. So looking at the literature, we find that aside from us, a few other papers have been published on 3D MRI CTA reconstruction and its potential benefits, but none of which has really systematically assessed operative decision-making, surgical workflow, and perfusion outcomes, which we plan to do. And previous work from our group has shown that using a software called Amira, we can reconstruct CTA and MRIs into one fused image, and this can help with operative decision-making. And we found that this actually helps with minimizing incision size and also minimizing or reducing surgical time. But we wanted to take this further. So we wanted to ask whether using combined CTA, MRI, 3D reconstruction can improve surgical workflow across different phases of the STA-MCA bypass surgery. And to do this, we're comparing our sort of standard or main practice, which is MRI reconstruction only, with MRI CTA reconstruction using the Amira software in a cohort of bypass patients matched for age and all kinds of clinical factors. So this is kind of the proposal and how we hope to generate this data. So we're very fortunate that we record every surgery we do extensively. So what we plan to do is to break up the surgery into distinct phases. So donor exposure, recipient identification, anastomosis, and patency check. And with this, we can hope that we can see whether we know that it minimizes surgery time, but we want to see which phase of the surgery it minimizes. So is it recipient identification with the added value of the contextualization of the vasculature in MRI or not? And finally, towards the end of this, for final outcome data, we want to measure cerebral blood flow with our CT perfusion scans and look at how symmetrical the blood flow is post-operatively. So you get a relative value from CT perfusion scans. But what we want to do is we want to use the contralateral and non-diseased hemisphere as a sort of internal control to see whether we've achieved efficacious perfusion. So our main outcomes are, as I mentioned before, decision-making, workflow changes, and perfusion. And of course, we'll match this with endpoint clinical outcomes as well. But the main point is the workflow and perfusion. So in conclusion, what I think about this project is that we can potentially have a look at, first of all, at whether 3D image reconstruction actually helps with STA-MCA bypass. But I think more importantly, we're adding to the literature and figuring out more ways to do research in this kind of field and get more concrete data, which I think is quite scarce in this particular kind of surgery. Thank you very much. I want to thank Mr. Demetriades for organizing this elective and Professor Kato for taking me, and all my funders as well for supporting my elective. Thank you very much.
Thank you very much. It's a great talk, and let me make sure the patients with ICA occlusion or MCA occlusion, what is the candidate for bypass? Who is the candidate for bypass?
So we're looking at patients with uh, uh, progressively stenosed MCA, I don't think we're going to go for full occlusion just yet,
Okay.
because I think that would involve a lot more variables that we can't really control.
Okay.
Yeah.
We have another questions. Dr. Biswas, please.
Thank you, Sensei. When I was in Pantane, I made a case report on STMCA bypass for steno-occlusive disease. It was a target bypass, minimally invasive. We have used two software, Amira and Geostation software, to detect the appropriate recipient, donor, and the distance. Overall target was to make it as minimal as possible. I want to ask that how this study differs from that case report.
Yeah. That's a good question. So I think the first thing is that just the nature of the study, we're looking at this in a much more systematic way across a larger cohort. So not just one patient, we're looking at across 40 different patients over the last couple of years. So I think this will give us more robust data. I think the second thing is that I want to look at specifically each phase of the surgery, not just sort of a snapshot at recipient identification. I want to look across every single phase and see whether, particularly if it improves sort of, how should I say, if it improves it's essentially ease of the surgery. Because we know that improves incision size, we know that improves potentially improves surgery time, but it's sort of taking it that step further with a larger cohort.
Okay, great.
Okay, thank you. Thank you.
And
Hi, one question is
okay, please.
Hi, Pros. So, do you think there is some motion artifact come in some noise motion artifact in this reconstruction procedures, or how do we eliminate this?
I think potentially there's motion artifact in the
Noise reduction, something there.
CTA, because I know the MRI you usually put it back
Resolution.
on
Yeah.
and you fix a head.
Hmm.
Pardon?
Yeah, okay.
Yeah. So I think with the MRI, I think there won't be much motion artifact. With CTA potentially, but I think because of the nature of the how should I say this? Because of the nature of the study is not to see how precise the imaging is, it's to see whether having all the images together in that 3D context helps the workflow. So I'm not looking at the precision of the imaging specifically, but it's sort of having that anatomy, preoperative anatomy, which is I think is more important. So there could potentially be artifact, but I don't think it's as important for this question.
Okay. So definitely great study, definitely pilot product. You require more studies also for this, but it's a great work. I appreciate.
Yes.
Thank you very
Can
much.
I-
Yes, please,
Okay.
go ahead.
So it's a very good, to me, it's a very good kind of 3D mapping, especially for pre-operative planning, especially for the beginners. For example, if first time I want to do epilepsy surgery, I need 3D mapping so that I got some orientation, surface marking, familiarity, and I can do a discussion, so shared decision making, and especially for complex cases. So how do you see the future of this mapping? Is it only for vascular, or can it be done for deep-seated complex vascular like AVM or fistula or something like that?
Yeah, no, absolutely. That's a good question as well. I think, sorry, I think the first thing is that at the moment, 3D reconstruction is very computationally heavy, so we don't do it for all patients. We do it for not for select few, but we do it for the more challenging cases, I think. So I think the first hurdle is to get past whether we can do this in a more efficient manner, which I think I'll eventually get to that point just with the technology, progression. But back to your point about AVM, I think it'd be incredibly useful for that because I think potentially even more useful because you're wanting to dissect away an AVM from like something that's adhered to the parenchyma, which I think it'd be an even nicer study as well. That's a good thing to yeah.
Yes.
But I think for all kinds of diseases, it's gonna be very useful. I think it's just a case of getting it to a point where we can implement it into daily practice a non sort of resistant way, a much more smooth way, so quicker. Yeah.
Very nice.
Yes.
それ先生いいですか？
はい。
Just he's just the medical student, not a doctor of the Edinburgh University. I'm very proud of him because he studied a lot.
Great.
Andreas. Thank you very much.
Excellent.
Thank you.
Excellent.
Good job.
Great.
Thank you.
Okay, then we are going to move on to the next. Actually, the next talk will be mine. Let me share my screen. Can we see okay?
Yes, please make it the presentation mode.
Yes.
Yeah, it's okay now.
So, shall we start?
Yes, please.
Okay. My name is Hiro Nakatomi from Japan, and I currently move on to the International University. Today's talk will cover our strategy of the management of brainstem cavernous malformations, which is rare, but someone has to take care. So let me summarize. So for this grave disease, we also created this type of 3D image, including the inside nucleus, tracts, and the nerves. And also while we are dissecting the tumor, we prefer to use this kind of the multimodal electrophysiological monitoring, including facial, motor, sensory, and extraocular movement. Those potentially all the relevant nucleus or motor tracts has been monitored. Then the really important message today is in the brainstem, we have 4 columnars, like the brainstem nucleus has aligned in sequence. Like let's think about the spinal cord. If you split the dorsal midline and expand it like an open door, then you can look at the brainstem as an open door spinal cord. From the midline, you will have the somatomotor nucleus at the very medial side. Then next, you will have the basilar motor nucleus. Then thirdly, you will have the basilar sensory. Then ultimately, on the surface, you have the somatosensory nucleus. There are 4 aligned columnars from medial to lateral. And in between visceral sensory and somatosensory, you should have the specially developed somatovisceral motor nucleus, which included the 7, 9, 11 solitary nucleus and the nucleus ambiguous. Also, we have to be careful. The facial nerve nucleus carries the tracts, go inside first, then go around the abducens nerve, then come back and exit from the brainstem. The major but the only motor nucleus is oculomotor, trochlear, and abducens and hypoglossal. Those columnar alignment is the key anatomical knowledge. And you have only to avoid these columnar place. You can split in between these 5 nucleuses. Then we can start from the midbrain. If we are taking care of the midbrain lesions, you can go through from the front or either from the back. If we have the dorsally aligned the tumor, you can go through the inferior or superior colliculus, or you can go laterally. Or for the ventral tumor, we go through the lamina terminalis. Let me show one case. This is the anatomical background. Through the inferior and superior colliculus, you can avoid any direct quick injury to the pyramidal tract as well as the spinothalamic tract. Spinothalamic and pyramidal tract is aligned laterally. Then one case, this lady came with this midbrain cavernous malformation, bled 4 times. And we did the similar surgical simulation with Dr. Bial, and we used the grid software, and we see the motor is red, blue is sensory. Then we are looking at the side of the midbrain. The cavernous malformation is sitting behind the sensory tract and frontal to the inferior superior colliculus. Then we can simulate, and also this lady has a developmental venous anomaly at the bottom of the tumor. Then we think we need to maintain the developmental venous anomaly. Then we decided to go through the lateral aspect through the subtentorial supracerebral approach. This is on the right side. We are opening up the both foramen magnum as well as the supracerebral cistern. Then we are looking at the right side subtentorial supracerebral area, then dissecting the arachnoid sharply. And we are looking at the discolored portion here. We see the trochlear nerve, and by stimulation, we are checking the alignment of the motor tract here. Then we confirmed her motor tract is here, and by using the pyoctanin dye marking, we confirmed that this area shouldn't be touched during the brainstem incision. We confirmed the most shallowest point. Then by making a 2 millimeter incision, then with the sharper forceps, we dissected the cavernous malformation from the brainstem parenchyma sharply and circumferentially and then centripetally. By creating a traction into the center, then we can dissect the adhesive area from the brainstem. But unfortunately, this lady had the last bleeding 38 weeks before. So there is so many adhesions between the brainstem. So this lady had this monitoring results. As for the MEP, motor evoked potential of the left hand dropped down to 44%, and her left hand SEP dropped down to 20% at the end. Then she harbored the remarkable motor weakness on the left side and recovered back to near normal in 2 years. So if we missed the golden time for the brainstem cavernous malformation resection, simply this patient gave me the lesson to wait for the next bleed. Then the next case came with this pontine cavernous malformation. Nowadays, many neurosurgeons are advocating to go to the pontine lesion. Let's go from front. This is a rationale for the coming into the front. The motor pyramidal tract is mostly aligned ventrally, and somatosensory tract aligned relatively dorsally. So around the trigeminal nerve root, we have several entry points here. So we can think about this mid-pontine lesions. We simulated this 3D image. Looks like the cavernous malformation is closely coming out from the under the trigeminal nerve. Then we simulated the sub-temporal approach as well as the anterior petrosal Kawase drilling. So you can see under the fifth nerve, you have the most shallowest protruding point of the brainstem of here. Then we decided to simulate a transzygomatic approach, then do the subtemporal craniotomy. Then we lift up the subtemporal temporal lobe. Then we are looking at the trigeminal nerve. And after creating the Kawase drilling, you can clearly see the out-poaching point on the mid right side pons. So we did the exact same surgery through the anterior petrosal approach. Again, by a direct simulation, we figured out her pyramidal tracts aligned ventrally. So we decided to cut near to the trigeminal nerve and created a 2 millimeter incision and hit the bleeding. Then again, dissect the cleavage plane between the gliotic area and brainstem parenchyma. We need to probably open up the several cyst, bleeding cyst, clot cyst, before reaching to the real bottom of the tumor. Then by creating the traction centripetally, and we often see this kind of the semi-perforating vessels, which we needed to coagulate briefly. Then at the bottom, we can use the navigation whether we have reached the bottom of the tumor. Then by dividing into two pieces, this big cavernoma has been out. Then for this lady, actually we didn't have any motor paralysis as well as a sensory paralysis. Looks to me the middle pontine fibers will protect the real pyramidal tract from these surgical maneuvers. Then actually her hemiparesis has improved. Then whenever we go through the back, if we have a dorsally aligned the mid-pontine cavernoma, we can choose the either suprafacial or infrafacial spot to go in the brainstem. The rationale for go in is again, the facial and abducens nerve nucleus is sitting very medially, so that you can use the lateral part like a ventral or dorsal vestibular nucleus can be go through to prevent any motor injury. Then we can also use this kind of the cerebromedullary fissure lateral around the foramen lusca, medial between the uncus and the tonsils. And if you open up this area perfectly, you can lift up the cerebral complex up to 2 centimeter or 3 centimeter. Then we can look at this case presented with 3 times hemorrhage dorsally poaching to the fourth ventricle. Then we simulated this gentleman too. Looks like his facial nucleus is here. Then this is a simulation. This cavernoma pushed the pyramidal tract frontally, ventrally, so that by accessing into the brainstem at the very far lateral point to the brainstem won't hurt anything. We are now approaching to the medial side of the, this is left side cerebellum, and we are looking at the dorsal fourth ventricle from the right shoulder. We are looking at this is obex, and by splitting the uncus, uvula, and tonsils, we can lift up the cerebral hemisphere far upper direction. We use this type of continuous stimulating monitoring for the facial calculus so that we can see how many % of the facial responses has been preserved during the operation. Then the surgical maneuver is the same, went into the this brainstem and lifting up the tumor capsule. with a centripetal and circumferential dissection. I skip this case. And this gentleman harbored the remarkable facial palsy because at the end, the amplitude declined down to 30%, and his left foot MEP responses dropped down to 30%. But he didn't have any real motor weakness, but he did have the worsened facial nerve palsy. Through this case, continuous facial colliculus stimulation should help to maintain the facial function. Then for this next case, I started to use, this is a similar patient, came with a dorsally aligned mid-pontine cavernous, and we did the similar simulation. We saw the cavernous is aligned in the center of the pons. We can think about anterior subtemporal approach or transtentorial supracerebral approach, or simply we can go from the below, like midline suboccipital, like this way, by lifting the tonsils and the uvula, we can go through the fourth ventricle. Then we did the similar operation, and by using the facial colliculus stimulator more seriously, then we decided to lift up the uvula and the tonsil more deeply, sharply, and we figured out her facial left side facial colliculus is here, and right side is here. Then we put the continuous facial nerve stimulator. This is a red stimulator, and creating the 2 millimeter entry and lifting the tumor from the dissecting the tumor after debarking the clot, dissecting the tumor capsule from around. Then fortunately, we made a special attention to not to move or deform the facial colliculus after the first case's experiences by paying the attention to special care to the facial colliculus. We have maintained the responses nearly 100%, and he didn't harbor any remarkable decline or worsening by monitoring, continuous monitoring. The last case, she came with medullary hemorrhage from the cavernous malformation. Then rationale for this approach, infrafacial approach is the same. We can avoid the ventrally aligned pyramidal tract as well as the spinothalamic tract whenever you go through the dorsal column. Then we have to be careful about the not too much injury for the glossopharyngeal nucleus ambiguous, and some solitary nucleus. We did the similar simulation. We clearly found her motor tract is ventrally aligned. We can go through this between the uvula and the tonsil area by splitting these fissures completely. We can lift up more fully cerebellum from the fourth ventricle to upwards. This is a real operation. We went through the midline suboccipital approach. We are dissecting the arachnoid over left side foramen lusca. Then we are dealing with right side foramen lusca. We are looking at accessory nerve and vagal nerve, as well as the glossopharyngeal nerve, and dissecting the arachnoid over uvula and the tonsil. Now, since this is a medullary brainstem cavernous malformation, we are now checking the glossopharyngeal nerve responses. Then we can lift the tumor capsule sharply or semi-sharply or bluntly by moving the tumor capsule to the center of this object. Then step by step, we can debulk by absorbing, suctioning the clot. Then we often see this kind of the semi-perforating fissures, which we need to coagulate precisely. Then after coagulating the tumor capsule, gently, we can lift up more and more. And finally, we can take out, for this patient, we could take out embroccoli. So this patient did show some responsive decline, but we didn't encounter any motor paralysis. But he did have the swallowing difficulty, which she needed the temporary tracheostomy, and which has been cured over next 3 months. Then I am reviewing our series. Looks like anterior approach will give you the better or easier functional preservation. If you go through the posterior approach, you still have the risk of the extraocular muscle weakness or facial nerve paralysis. And also the first case, we missed the golden time for surgery. If we missed the golden time of dissection, the tumor capsule from the brainstem, we probably need to postpone or cancel the surgical resection for the next breed. Then this is a conclusion. We did this type of simulation from 2010, and now 16 years of experience give us the chance to develop the surgical software, which name is whose name is Grid. You can look at the website, and also we do have the continuous stimulating electrode and calculating monitoring device, so that we can figure out even in the brainstem surgery how many % of the neural function has been preserved during the operation. Thank you very much for your attention.
Thank you so much, Professor Nakatomi. I can
Yes.
see Dr. Mao raised his hand. Any questions from Dr. Mao? Please unmute yourself.
So,
Yes, please unmute yourself. Yeah.
Mouse mute.
すいません。Thank you for your wonderful presentation. So I'm Mao Yokota from Aichi Medical University. So I performed always endoscopic surgery. So always for in the case with cavernous malformation on brainstem, we insert a 6 mm cylinder.
Okay.
Millimeter cylinder, but you said your incision is only 2 mm.
Initially, just at the beginning. So it can be enlarged up to the 10 millimeter or 8 millimeter.
So how do you think about 6 mm cylinder? Is it okay?
I think it's a wonderful idea to take out the brainstem cavernous malformation by a cylinder surgery. But the only concern is if you are adequately skilled to take out the brainstem material by cylinder narrow field, we might not be able to place the electrode for the functional monitoring. Then we can combine both your cylinder technique with our monitoring. Big craniotomy plus small cylinder window with monitoring might help for the complete resection plus better functional preservation. That might be future style.
Thank you. Thank you so much.
hello, Professor. As a
Yes,
Yes.
Professor.
Great insight on the no man's land. Definitely is this land is very no man's land. Every surgeon is very difficult to touch this area. But with the help of your talk, definitely with the help of your that was software is very good.
Yes,
So
thank you.
the preoperative simulation so that we can plan from anterior or posterior depend upon
Yes.
which approach is about. That's the most important crux. At the same time, I think cylinder surgery is good role, but intraoperative neuromonitoring is the most important thing because you have to preserve all the corticospinal tracts, you have to preserve all the nerves, or you have to preserve all the facial and everything. So that will the main crux because the preservation and function is the most important thing. Just removing the cavernous bleed is not this one. So I think your talk is fantastic and wonderful. You totally cover the upper pons, midbrain, and all areas with all your examples. Also very good. And you said that anterior approach is definitely better as compared to the posterior approaches. How Miss Kai can't understand because posterior you can directly go, but anteriorly is very difficult to enter this area. So can you please elaborate again?
Yes, thank you very much for asking and your comments. And you know, go through the fourth ventricle is
Yeah.
easier
That's why I'm asking.
for as approaching things. But if you are learning anterior petrosal or posterior petrosal approach as your own tool, you can easily go to there. Because after completing the anterior petrosal approach, the brainstem is pretty shallow and near to your hand. And it's a different world. So if you are eager to train and get the petrosal approach into your practice, probably your style might change.
Okay.
Yeah.
Thank you.
黒崎先生お願いいたします。どうぞ。
Professor Nakatomi, thank you very much for a nice presentation and beautiful pictures. My question is look like same the Mao Yokota. As you said, 2 millimeter opening initially. I have also had experience performing surgery for pontine cavernous malformation. I tried at first 2 millimeter opening, but as you said, during the dissection of the cavernous malformation, the opening of the pons is a little bit larger, 3 meter, 4 millimeter, 5 millimeter. And do you have some special technique to maintain the opening of the pons of the cavernous to enter the cavernous sinus? 3 meter, 4 millimeter.
Thank you very much for asking. And there is a technique. Let's say you can use some, what can we say, some Surgicel or any seat material and created the diameter of 10 millimeter circle from the beginning, then or 8 millimeter. Then whenever the entry point gets too large, and like 5 millimeter, you can apply this circling material right onto the brainstem so that you wouldn't hurt beyond the circle. Then whenever you have the larger entry, you can put the circle in there. Then this circle will protect to expand beyond the determined diameter. So that kind of the limiting circle technique might help.
Thank you. I'll try.
Yes.
So are there any comments from the floor? If not, I think it comes to the end of all the presentations. Shall I invite the comments from Professor Kato?
Asmin, you first, please.
Okay, thank you very much to everyone. I think this joint ACNS ISMIN demonstrated that collaboration between the senior most experienced surgeon and the enthusiasm among the young colleague and emphasize on the a lot of new technology that emphasizing on the minimally invasive technique that allows we can enter to the difficult area which known to be high risk become easy, safe, and very precise, and also improve outcome. So I would like to congratulate everyone who participate in this joint webinar. So I also would like to thanks, of course, Professor Yoko Kato, ACNS, and the young neurosurgeon like Rajakuti, Ben, Mao, and the rest for make this possible. I'm sure that despite the heavy schedule that everyone can spend time, and this joint webinar will be continued. We will have a series of lectures, and please promote this among our colleagues. And we also will have our ISMIN Congress in Shanghai from 4th to 6th September. So please mark your calendar. Of course, the CNS also, ACNS Congress in Mumbai soon. So maybe Professor Yoko Kato would like to add something else, Prof.
Thank you so much. So nothing more after you, I think. Thank you very much for always your support. It means the very interesting. So I think that today's we had 5 lectures, and we learned a lot, of course. But the preoperative, the image is advancing the more and more. So it helped us a lot, I think, especially the Nakatomi sensei, that he deal with a very difficult brainstem area. But if we have such a same model, maybe we can have a better surgery like him. But in the future, I think not only for the experts, the treatment or surgery, but also I think everybody can do. So that is our ideal, the final surgery, I think. So thank you very much for all of you. A bit longer, we learned a lot. Thank you very much. Thank you so much.
And thank you so much to all the speakers and chairs. So maybe I have just used up the last 1 minute to share the future coming event of the ACNS, and the next one is coming would be the 15th ACNS Congress in Mumbai, and will be from the 30th of July to the 2nd of August in Mumbai, and it's open lectures, and I hope all of you can join. And during the Congress, we'll have the Fujita Health University alumni cocktail reception with Professor Kato and Professor Go on the 1st of August. And please join if you're interested. And also we'll be having the ISMIN Congress in we'll be having the ISMINS Congress in the September 4th to 6th in Shanghai. And if you're interested, please scan the QR code for the ISMIN Congress. And last but not least will be the 4th World Congress of Neurosurgeon will be held in the 30th of October to the 1st of November. So sorry for the delay, but still I think we have a great and educational night today. And with that, I would like to end our section, and thank you to all the chairs, the speakers, and the discussants, and thank you so much.
ありがとうございました。お疲れ様でした。黒崎先生、ありがとうございました。
ありがとうございました。
Thank you, Asmi. Mao 先生、ありがとうございました。
Thank you very much.
Thank you very
Terima
much,
kasih.
everyone. Terima kasih.
Thank you very much.